Good evening, delegates and participants. Thank you for joining Shield Connect. Today we have a special guest from Lucknow, Dr. Smita Tandon, and ma'am is going to take on topic menopause and quality of life as today is menopause day. So before we start with the session, let me give a little introduction of our page Shield Connect, and then I will introduce our speaker. So this is our page shieldconnect.in where you can find different sections are available. Like in blogs, you can find all the blogs written by eminent speakers and doctors. Then we have a webinar section. So for today's webinar, you can click on this webinar, and here we have a live comment section. So you can post your queries. So at the end of the session, we can have a Q&A with our speaker for the day. Then we also have a 1 minute. So we have a leader section. So you can find all the details regarding the doctors who are connected with Shield Connect. So this is our page Shield Connect. And now let me introduce our speaker for the day, Dr. Smita Tandon, ma'am. Ma'am has done MBBS, DGO. Ma'am is working as a senior obstetrician and gynecologist and consultant in Jamuna Seva Sadan and Heart Care Center, Shivpur, Varanasi. Also, King George Medical College from Lucknow. And ma'am is a member of the Social and Cultural Committee of VOGS, Varanasi Obstetric Gynecology Society, life member of FOXY, Indian Menopause Society, IFS. The field of interest is infertility, high risk pregnancy, and preventive oncology. So, ma'am, we are glad to have you on our platform for today's session. And I hand over the session to you, ma'am. Thank you so much, ma'am.
Thank you so much. Today is the World Menopause Day. So, on this auspicious day, we are having a very good topic. Please, can you share the slide? Very interesting topic, menopause and quality of life. Because life just changes after menopause. There is an overview of National Family Health Study. World Health Organization defines natural menopause as the permanent cessation of menses confirmed only after 12 consecutive months of amenorrhea. In general, the natural menopause occurs between 45 and 55 years of age. In India, the range of mean age at menopause reported in different studies appears to be rather young, between 41.9 and 49.42. According to the Indian National Family Health Survey carried out during 2005 to 2006, about 18% of currently married women in the age group of 30 to 49 years had reached menopause. Next, please. Concern has been expressed that the rates of premature menopause before the age of 40 years are high in India and may be increasing in certain sections of the population. For example, NFHS 24 showed that 3.1% of women in the age group of 30 to 34 years and 8% among 35 to 39 years age groups were in menopause. It further showed that 22.1% of the women in the age group of 35 to 39 years in Andhra Pradesh were in menopause, a potentially significant observation as this state has a high prevalence of female sterilization at a young age. However, these data included both natural menopause and hysterectomy. The proportion and absolute number of Indian women aged 45 years and above is likely to increase substantially in the next few decades. According to the 2011 census of India, there were about 96 million women aged 45 years and above. This number is expected to increase to 401 million in 2026. As the postmenopausal years are associated with health risks such as hypertension, heart disease, osteoporosis, and decline in the overall quality of life in this group will present profound future challenges. Next, please. Individualized plan for menopause. Each woman needs an individualized health plan management. It is more important to distinguish between a symptomatic and an asymptomatic menopausal woman, but either woman is symptomatic or she is asymptomatic. Both have the complete preventive health checkup is very important, and the physician's roles come in between. There are few symptoms of menopause. The symptom complex can be divided into vasomotor symptoms, somatic symptoms, genitourinary syndrome of menopause, and neuropsychiatric symptoms. Menstrual cycle shortening of cycles that occurs in the late reproductive years is a clinical marker for the onset of menopause. Later, it is a lengthening of the intermenstrual interval, and some may have sudden amenorrhea. Vasomotor symptoms. Most bothersome symptoms of menopause and the most common reason women seeking for medical care. Vasomotor symptoms are associated with a sudden sensation of heat in the face, neck, and chest and persist for several minutes or less. During a hot flush, skin temperature rises due to peripheral vasodilatation, particularly in the fingers and toes. Along with peripheral vasodilation and sweating, heart rate increases 7 to 15 beats per minute. It may occur. It may take 30 minutes or longer for the skin temperature to return to baseline. Duration of vasomotor symptoms. The population-based prospective pan-ovarian aging study enrolled older reproductive age women with regular menstrual cycles and followed them over 16 years. The mean age of participants was 42.2 years at baseline and 51.5 years at the time of the final menstrual period. A key finding was that the median duration of hot flushes reported by women to be moderate to severe was 10.2 years. Women whose symptoms began around the time of onset of the perimenopausal transition, the median duration of symptoms was 11.6 years. Somatic. Joint aches and pain are commonly reported symptoms among women at midlife. Women who are obese or depressed are more likely to experience joint pain. There also appears to be association with menopausal status, with peri and postmenopausal women experiencing more joint pains than premenopausal women. Body composition. Although women typically gain weight during midlife, it does not appear to be due to menopausal status or stage. In the early postmenopausal years, women typically gain abdominal fat mass and lose lean mass. Skin changes. The collagen content of the skin and bones is reduced by estrogen deficiency. Decreased cutaneous collagen may lead to increased aging and wrinkling of the skin, frontal balding, and hirsutism. Genitourinary syndrome of menopause, GSM. Vulvovaginal atrophy of GSM refers to the physical changes of the vulva, vagina, and lower urinary tract that result from the estrogen deficiency. Adversely affects health, sexuality, and quality of life of many menopausal women. The prevalence of urogenital symptoms in the postmenopausal in the IMS study was 15%. It presents as vaginal dryness in 32%, pruritus valve in 10 to 17%, and dyspareunia and urinary urgency in 10% of cases. Physical signs of vulvovaginal atrophy are variable and include reduced vulvar fat, reduced vaginal rigidity, and blood flow, leading to a pale appearance. A change from moderately acidic range, pH 3.5 to 5, to a neutral range, pH 6 to 8 in the vaginal pH. There is a shift in the vaginal maturation index. Vaginal lubricants and vaginal moisturizers can be offered for vaginal dryness and dyspareunia. Local estrogen therapy is the first line of management, the only contraindication being active estrogen dependent tumors. Sexual problems. Vaginal atrophy with aging may lead to dyspareunia, causing sexual dysfunction, which is corrected by local estrogen therapy. Acquired sexual desire disorder in some women respond to testosterone therapy. Formulations of testosterone for use in women are not available in India. Testosterone preparation meant for males should not be prescribed for women. Tibolone is a good option since it contains androgenic activity and can be used to treat in libido problems, but probably tibolone is not available now in India. Central nervous system. The core mental functions are memory, communication, and language. Ability to focus and pay attention, reasoning and judgment activities of daily living, and visual perception. Impairment of two functions is suggestive of dementia. Many dementias are progressive. Early diagnosis allows a person to get the maximum benefits from available treatments and provides an opportunity to plan for future. For best preservation of memory and cognition, women should be advised about the importance of good overall health, good cardiac and vascular health, exercise, maintenance of active mind, avoidance of excessive alcohol consumption, and measures to reduce risk of diabetes and hypertension. At present, MSC is not indicated for neuroprotection. Depression. There is a significant increased risk of new onset depression in women during the menopausal transition compared with their premenopausal state. Cognitive changes. Evidence supports the relation of estrogen to cognitive function. Women face problems with memory loss and difficulty in concentration at menopause transition. A definitive role of MST for treating cognitive symptoms without VMS is lacking. Sleep. Peri and postmenopausal women sleep less, have more frequent insomnia, and are more likely to use prescription sleeping aids. Perceived decline in the sleep quality may be attributed to general aging effects, for example, nocturnal urination, sleep-related disorders, for example, apnea or other illness, for example, chronic pain and depression, stress, negative mood, ovarian hormonal changes. Hot flashes can trigger awakenings in the first half of the night, but REM in the second half suppresses thermoregulation, thus hot flashes. Decisions on whether and how to treat with behavioral or drug therapy or both depend on severity of sleep disturbances, context of sleep problem, for example, distressing hot flashes or life stress, severity of daytime consequences. Next, please. If insomnia is identified, medical or psychiatric causes of insomnia should be ruled out, and if present, it should be treated accordingly. Lifestyle modification should be recommended as a first-line treatment. If lifestyle modification don't work, then hypnotic, benzodiazepines, or melatonin agonists can be used in the short term, but there is no definite or convincing evidence to suggest its efficacy. These should only be prescribed by supervision of psychiatrists or sleep experts. Mind-body therapies such as yoga have some evidence but need further rigorous studies to prove its effectiveness. Mood disorders. Feelings of upset, loss of control, irritability, fatigue, and blue mood dysphoria at midlife may be caused by fluctuating hormone levels that perturb neural system transiently. Women with a history of premenstrual syndrome, significant stress, sexual dysfunction, physical inactivity, or hot flashes are more vulnerable to depressive symptoms. The most predictive factor for depression at midlife and beyond is prior history of clinical depression. Relaxation and stress reduction techniques, antidepressant and counseling, or psychotherapy are options to consider in symptom management. Urinary symptoms. Urinary complaints are common in midlife women, but no link to menopause-related estrogen loss has been identified. Over 50% of women more than age 50 with urinary incontinence also report symptoms of overactive bladder. Mild incontinence in early perimenopause tends to decline in the first 5 years after menopause. Weight loss for overweight women is effective. Kegel exercises can cure more than 50% of cases of stress incontinence when performed regularly. Osteoporosis. Serious health threat for aging postmenopausal women by increasing risk of fracture. 13% to 18% of white American women more than or age 50 have osteoporosis of the hip. Lower estrogen levels account for about two-thirds of bone loss during the 5 to 7 years around menopause. Definitions based on BMD is that normal T score greater than or equal to -1, low bone mass osteopenia T score between -1 to -2.5, osteoporosis T score less than or equal to -2.5. Osteoporosis risk factors for osteoporotic risk factors in sex 10 years calculator. This is the advanced age 50 to 90. Parental history of fragility or fracture, female sex, current tobacco smoking, weight, long-term use of glucocorticoids, height, rheumatoid arthritis, low femoral neck BMD, prior fragility fracture, alcohol intake more than or equal to 3 units per day, other causes of secondary osteoporosis. Osteoarthritis, epidemiological studies of a potential role for estrogens in osteoarthritis showed two very different findings. First, estrogen deprivation at the menopause seems to be associated with increase in the frequency of knee, hip, and finger osteoarthritis and in the severity of hip osteoarthritis. Second, MST for the menopause may decrease the incidence and progression of hip and knee osteoarthritis. Cardiovascular diseases. Cardiovascular disease, including CLG and stroke, is second leading cause of death among US women aged 45 to 64, leading cause of death for women more than 65. CLG death rates in younger women aged 35 to 54 are increasing for first time in 4 decades, secondary to obesity, diabetes, and hypertension. For better cardiovascular health, total cholesterol should be less than 200 milligram per deciliter. At HDL 50 milligram per deciliter, LDL less than 100 milligram per deciliter. BP should be less than 120 or equal 120 80 millimeter of mercury. Fasting blood sugar less than 100 milligram per deciliter. BMI less than 25 kilogram per meter square. No smoking. Physical activity more than 150 minutes per week, moderate, or more than 75 minutes per week, vigorous for both. Healthy DASH-like diet. Cancer. Menopause is not associated with increased cancer rate, but because cancer rate increases age and cancer is second leading cause of death in women, is screened for the following cancers regularly. Breast cancer, mammogram every 2 years, age 50 to 74. Colorectal cancer, colonoscopy every 10 years, or fecal occult blood test, sigmoidoscopy, ovarian anemia every 5 years, beginning at age 50. Endometrial cancer, evaluation of any postmenopausal bleeding with pelvic ultrasound or endometrial biopsy. Ovarian cancer, no satisfactory screening test, but timely evaluation needed if presenting with bloating, pelvic pain, or urinary urgency. Cervical cancer, pap smear, pap test every 3 years or every 5 years if combined with HPV test. After a normal report, 3 years in a row for women aged 50 to 64. Screening not necessary, more than 65 with 3 or more normal pap tests in a row or abnormal pap in past 10 years or 2 or more negative HPV tests in past 10 years. Now we come to treatment. Next slide, please. Hormone replacement therapy, MHT. Hormone therapy tablets, patches, or cream is used to replace the estrogen that ovaries no longer make during and after menopause. Hormone therapy may have either estrogen alone, estrogen plus progesterone. Generally, use of SRT for a short period of 3 to 5 years has been advised. Reduction of doses should be done as soon as possible. Indication of SRT, relief of menopausal symptoms, prevention of osteoporosis, to maintain the quality of life in menopausal years. A special group of women to whom SRT should be prescribed: premature ovarian failure, gonadal dysgenesis, surgical or radiation menopause. If risk of hormone therapy, endometrial cancer, venous thromboembolic disease, increased risk within 1 or 2 years after initiation of hormone therapy. Breast cancer, increased breast density with progesterone's bioproliferation of estrogen-dependent mammary tissue, making it more difficult to detect breast cancer early with a mammogram. Ovarian cancer, more than 10 years. Estrogen therapy, cardiovascular accidents, lipid metabolism, and increased incidence of gallbladder disease have been observed following ERT due to rise in cholesterol. Next, please. Use of hormone replacement therapy and risk of breast cancer. There's an aspect case control studies using the Q Research and CPRD databases. There's a conclusion. This study has produced new generalized estimates of the increased risk of breast cancer associated with use of different hormone replacement preparations in the UK. The level of risk varied between types of SRT with high risk of combined treatment and for longer duration of use. Next, please. Commonly used estrogen are conjugated estrogen 0.625 to 1.5 milligram per day. Progestin use are medroxyprogesterone 100 to 300 milligram per day. Considering the risk, hormonal therapy should be used with the lowest effective dose and for a short period of time. Low dose of oral conjugated estrogen 0.3 milligram daily is effective and has got minimal side effects. Progestin with history of breast carcinoma and endometrial carcinoma, progestin may be used. It may be effective in suppressing hot flashes and it prevents osteoporosis. Methoxyprogesterone acetate 2.5 to 5 milligram per day can be used. Next, please. Tibolone. It was we were using previously. Tibolone is a steroid having weakly estrogenic, progesterogenic, and androgenic properties. It prevents osteoporosis, atrophic changes of vagina, and hot flashes. It increases libido. Its dose was 2.5 milligram per day. These are Cochrane findings: soya phytoestrogens, black cohorts, increased interest in soya isoflavones, weaker estrogen supplement over the years, no conclusive evidence of improvement in menopausal symptoms in 43 randomized trials. A meta-analysis of black cohorts reported insufficient evidence to support the use of black cohorts for menopausal symptoms. Thus, isoflavones are not a suitable alternative to hormonal treatment. There is a conclusion of soya isoflavones in the prevention of menopausal bone loss and menopausal symptoms. Is a randomized double-blind trial. In this population, the daily administration of tablets containing 200 milligram of soya isoflavones for 2 years did not prevent bone loss or menopausal symptoms. Ideal menopause solution: it should regulate endogenous estrogen to non-reproductive organs and reproductive organs. Should offer symptom relief as good as HT without risk of cancer, VT, and stroke, which may be associated with HT. The ideal menopausal solution should be estrogen affinity to ER. This must be upregulation of non-reproductive organs like vasoepithelium, bone, and brain. And there should be reproductive organs, breast and endometrium. There should be downregulation of estrogen affinity to ER. Next. There are few medical hubs. The following active ingredients have shown promising results. There's a Cyanencum wilfordii, Phlomis ambrosa, and Angelica gigas. Cinnamic acid, Cyanencum wilfordii 2.57 microgram, S-methyl Phlomis ambrosa 0.129 milligram, and decusin and decusinol angelate in Angelica gigas is 1.0023 milligram. There are some medical hubs. Ceramic acid, a natural remedy used for hundreds of years in both Korea and China, has shown significant improvements in the quality of life for women dealing with the symptoms of pre, peri, and postmenopausal. There is a study of Lisa Oliva, 2015. Angelica gigas, ultra-fine Angelica gigas powder normalizes ovarian hormonal levels and has anti-osteoporosis properties in overexamized rats. There's a Keong OK Choi et al. 2012. Herbal formulation composed of a combination of Cyanencum wilfordii, Hemsley, Phlomis umbrosa, and Angelica gigas extracts have been used for treating menopausal symptoms. Shi Jong Kim 2017 recently. This shows premenopause, menopause, and postmenopausal balances. There's a Estro G100 in doses of 1 BIG. This regulates estrogen affinity to ER. It upregulates the estrogen affinity to ER in non-reproductive target organs. In vasoepithelium, it reduces hot flashes, night sweats. In CNS, it improves mood swings and insomnia. And in bone, it improves DND. And there's a down regulation of estrogen affinity to ER in reproductive target organs like breast and endometrium. And there's a no proliferation of MCF7 cells, which reduces the risk of cancer. There's a three randomized placebo-controlled trials adhering to international ethics committee norms. One conducted in USA, two in Korea, published in renowned journals. Both objective and subjective parameters validated extensively. Evidences: vaginal dryness, hot flashes, mood swings, and bone pains. Relief symptoms within 7 to 14 days. There's a study concluded subjects on HG 100 group had significant reduction from 10 out of 12 Cooperman index symptoms. There's an evaluation of effectiveness and safety of HG 100 on perimenopausal women for 1 year. This study demonstrated HG 100 improved bone health parameters significantly. This reduces the osteocalcin and alkaline phosphatase and increases femoral bone mineral density. There's a biochemical evidence. There are 5 parameters were taken. Increased bone mineral density, increases serum growth hormone, decreases serum calcium, decreases serum triglyceride, and decreases serum alkaline phosphatase. NIH study shows this 5 times more effective. There's an evaluation of effectiveness and safety of HG 100 on perimenopausal women for 1 year. Conclusion was there the objective these research were designed to investigate the effects of non-hormonal treatment HG 100 developed for perimenopausal women. Conclusion was treatment with HG 100 for 3 months in patients with menopausal symptoms showed improvement of climatic symptoms including hot flashes, joint pain, and exocrine secretion. In the treatment of HG 100 for 12 months, human growth hormone was significantly increased. The effect of improvement of bone metabolism markers was shown, and the increase of femoral bone density was observed. However, after HG 100 treatment, the increase of weight and BMI was not shown. The increase of serum triglyceride concentration, as is commonly observed with HRT, was not observed. Rather, the concentration was decreased in result. In result, while side effects that is common with HRT were not observed for 12 months long treatment, the improvement of menopausal symptoms was confirmed. The treatment of menopausal women with HG 100 is observed to be effective and safe for the improvement of symptoms. Therapeutic lifestyle management is also has got very important role in the management of menopause. Eat right, exercise regularly, and medication as advised by doctor. Therapeutic lifestyle management, physical activity, targeted exercises, nutrition, avoid alcohol and tobacco, stress reducing strategies, medication and paced respiration, massage, hobbies, nutrition, new emotional stability, positive attitude, family involvement, spiritual attitude, and proper sleep. This is very important, balanced and nutritious diet in the role of premenopausal, perimenopausal, and postmenopausal women. Recommendations: sugar 6 tsf per day, salt 1.5 tsf or 3 to 5 grams per day, oil 2 levels teaspoon per day, fruits 100 grams per day, vegetables 300 grams per day, drink 8 to 10 glasses of water every day, add powdered flaxseed, cinnamon, fenugreek, soft in salads and whatnot. Next, tea, coffee and dairy products. Avoid more than 200 milligrams per day of caffeine. Limit intake of tea and coffee to 3 cups a day. 150 ml of brewed coffee is equal to 120 milligram of caffeine. 65 milligram of 1 cup of instant tea and coffee. Consume a minimum of 5 to 600 ml of milk or curds to build or calcium banks in bones. Support it with lots of vitamin C, fruits, vegetables to favor calcium absorption. This is also very important. Mind your sleep. Go to bed and get up at the same time each day. Sleep in a dark, quiet room at a comfortable temperature. Avoid large meals. Exercise regularly. Caffeine, nicotine, and liquids 2 hours before sleep should be avoided. Maintain dim light bedroom environment with no gadgets around. This is management of osteoporosis. Postmenopausal women asymptomatic. more than 5 years post-menopause or less than 5 years post-menopause. If there is a more than 5 years post-menopause and asymptomatic, it should be BMD by DEXA at hip or spine. And if it is, it could be normal, osteopenic, osteoporosis, or severe osteoporosis. If it is less than management of osteoporosis, yeah, previous slide, please. Previous slide. If this is less than 5 years post-menopause, if there's a one major risk factor and only two other risk factors, that it should be BMD by DEXA get done at of hip and spine, and it could be divided into four categories: normal, osteopenia, osteoporosis, severe osteoporosis. Now we come to four categories. Next slide, please. These are normal: osteopenia, osteoporosis, severe osteoporosis. If it is normal, follow-up of 2 years later, reinforce satisfied changes. If it is osteopenic, it could be no risk factors or it could be associated with one major risk or more than two other risk factors. If there is a no menopausal symptoms, then it is follow-up of 2 years later. If it is menopausal symptoms, then it should be patient should be given ST tibolone, biphosphonate, siloxane, strontium granulate. If this patient is osteoporosis, if there is no menopausal symptoms, then it should be given nothing. It should be given hormonal treatment, tibolone or biphosphonate. If there is no menopausal symptoms, still it should be given biphosphonate, hormone therapy, riloxafen, strontium granulate. If there is a severe osteoporosis, then patient should be given teripeptide, biphosphonate along with calcitonin. MST within 10 years of menopause is very important, and it should be stopped as soon as possible, and dosage should be reduced by the time. Management of osteoporosis postmenopausal women with fragility factor, immediate pain relief is important. Surgical management should be done. Calcium, vitamin D supplementation, investigations, routine hematological, rule out secondary causes like secondaries. It should be follow-up and multidisciplinary management should be given. BMD is fine hair by DEXA, repeat after 1 or 2 years. Bone markers for monitoring therapy. It should be lifestyle management, pharmacotherapy, teripeptide, biphosphonate, calcitonin, pain relief in vertebral fracture. Physiotherapy should be associated. Rehabilitation is very important. Emotional and social support is very important. Identify factors for recurrence, and aim should be independence at home and work. Living with menopause, nutrition, the recommended dietary allowance of calcium and vitamin D for adult Indian. Calcium more than 800 milligram per day to 1200 milligram per day. Upper limit is 25 milligram per day, but it should be avoided in the renal, kidney and stones cases. Vitamin D is 1500 to 200 international units. Upper limit of 200 of normal is 10,000 international units. Type of calcium supplement, there are different type of calcium: calcium carbonate, citrate, gluconate, lactate, phosphate, tribasic. Naturally derived calcium from like dolomite or sessile bone meal may contain lead and other toxic materials. There's a difference between calcium carbonate versus calcium citrate. Calcium carbonate needs acid to dissolve. Calcium citrate doesn't require stomach acid. Calcium carbonate less stomach acid at the age need more than cause poor absorption is there. This is 50 times better absorption. It should be taken with meals. Calcium carbonate. It should be calcium citrate can be taken anytime. Calcium carbonate is the least expensive form of calcium. Its calcium citrate may cause smoke. Calcium gluconate, calcium lactate, calcium phosphate have less calcium than the carbonate and citrate form. Calcium supplements, thyroid medications, corticosteroid, tetracyclines, and anticonvulsants and calcium should be taken separately. Contraindicated in patients with hypercalcemia, renal insufficiency, and with caution in nephrolithiasis. Excess amounts more than 2500 milligram a day affect kidneys and can reduce the absorption of other minerals like iron, zinc, and magnesium. Management of vitamin D deficiency. Cholecalciferol vitamin D tablet or powder 60,000 international units once a week for 8 weeks, preferably with milk. One IM injection of 6 lakh international units is given to correct the deficiency, not to be repeated before 3 months, and may be given after confirmation of persisting low levels of vitamin D. Maintenance therapy from natural sources or supplements is advised after correction of the deficiency. Maintenance therapy, polycalciferol tablets or powder 60,000 international units once a month in summer or twice a month in winter, because we can take the sunlight also. Vitamin C, vitamin D supplements by oral spray or oral tablets of 2,000 international units per day. Injection of polycalciferol 3 lakh international units IM twice a year or 6 lakh international units IM once a year. Polycalciferol 1000 IU daily will raise blood levels on average by approximately 10 nanogram per ml. Conclusion is women live one third of their lives in postmenopausal period. Perimenopausal and postmenopausal women may be affected by symptoms and conditions associated with hypoestrogenism like vasomotor symptoms, vaginal dryness, and osteoporosis. In most women, hot flashes usually resolve without treatment. And HRT has its severe drawbacks. Non-hormonal management is the best choice of treatment in menopausal issues. Complementary and alternative medicine is an efficacious treatment strategy. Eating the right diet along with supplements, having adequate sleep, and exercising regularly can lead to a blissful postmenopausal life. Thank you so much. Thank you.
निशान before coming Nishan ma'am, so would like to thank you ma'am once again ma'am for accepting for conducting webinar on this day madam, menopause awareness day. We are also thanking madam Shield Healthcare, so entire Gynec fraternity madam for dedicating their unique efforts and a special contribution to raise awareness on menopausal health ma'am. Thank you so much ma'am.
Is there any question in that?
Yeah, just give me a one moment madam. I'll just call Nishan,
Hello.
so he'll be able to ask some questions. One moment ma'am. Yeah.
Hello,
Yeah,
ma'am.
Nishan.
Yes,
Yes.
ma'am. Okay, okay, okay. So, ma'am, let me check if you have any query in
Yeah,
our.
please check the chat box if there is any question.
Yes, ma'am. Yes, ma'am. So, ma'am, there is one question. Please suggest how to treat insomnia in menopausal patients.
In menopausal women, if there's an insomnia, there's a very common feature. First,
Hmm.
that daytime, that woman should not take sleep, first of all. And
Mhm.
secondly, she should take her food at least 2 hours before sleep.
Okay.
And she must walk after food. Then, if she can exercise a light exercise in a form of walking, then she can take the proper sleep. And if there's a like any depression features are associated, then she should take the help of any psychiatrist.
Yeah. Then we received two feedbacks. It was the nice presentation. It was very crisp talk on this topic. So, ma'am, thank you so much for giving your valuable time with us on today's webinar on Shield Connect, ma'am, and we would like to have more sessions with you on Shield Connect platform, ma'am. Thank you
Thank
so
you.
much, ma'am. Thank you,
Thank
ma'am.
you so much. Thank you. Okay.
Thank you so much, ma'am, for joining with us.
Thank you. Thank you so much.
Thank you, Nishant.
Ma'am.
Have a nice evening.